affiliations with the organization that we will be talking about today. The objectives for learners today. Okay, thanks. Thank you. Can people hear me all right? Okay, good. I'm hearing up more. Let me try to. How about that? Super good, is it? Maybe I should just clip it to my cheek. How about that? Oh, that's good. Okay, great. Okay, thank you. All right. Whenever I'm deposed by attorneys, it's always the same problem. There's something about my tone of voice that's too low or soft or something. So good news for the future when you're deposed. If you have a soft voice, they may not hear you. All right, learner objectives. I want you to be able to define measurement-based care, to describe the newly revised Joint Commission behavioral health care requirements regarding the use of outcome measures that will be effective January 1st, 2018, to be able to discuss the rationale for the revisions, and to identify validated symptom rating scales for use in behavioral health. In this talk, I'm highlighting public domain available rating scales, but there's also some wonderful rating scales that you have to pay a fee in order to use. So realistically, probably a number of physicians won't use those kinds of rating scales. However, in the child domain, there are some really good rating scales that look at how children are functioning across multiple domains, and some of those best capture child problems, because child problems are often not easily captured by just a simple symptom rating scale about anxiety, depression, ADHD, etc. So measurement-based care, this is not the Joint Commission's definition. This is the best definition, the most easily understandable definition I could find when I was looking through literature on this topic. Measurement-based care is the systematic administration of rating scales with the use of the results to determine clinical decision-making for individual patients. You can also extrapolate that to organizations using aggregated data from evidence-based rating scales for the populations they serve. They can then analyze effectiveness of the organization. And what we do with a measurement-based care is use objective validated measures to track treatment impact over time. Data, very importantly, needs to be collected at multiple points in time. And then we use the data to monitor and evaluate progress. The rationale. So the reason that measurement-based care started to be addressed by Joint Commission was there was more and more data that supported the efficacy of using measurement-based care to improve clinical outcomes. And it has been found to help organizations improve their quality of care, so organizations that are Joint Commission accredited, and also helps them determine if the services are working, and if they're not, to aid in adjusting services. Of course, that also applies to the individual clinician. We can use those rating scales to look at the impact of our treatment interventions and hopefully more quickly make changes in course if it looks like the treatment is not effective. To be effective, and this is really an important point, the rating scales need to be used with enough frequency to help clinical decision making. And so it is easy in clinics to use, say, a PHQ-9, like is used in the MEAC clinics. The PHQ-9 is the Patient Health Questionnaire 9. It assesses the domain of depression. It, I think, standardly is given in MEAC clinics as a kind of screener for people. But the importance of making so for these measurement-based care to be effective, we need to actually look at the results of those rating scales and not afterwards. So it's easy for example, the ladies that work in our clinic, they have a batch of paperwork, the ladies at the front desk, that they give all patients. And They collect those from the patient when they're completed, and then they call the clinician and say, your patient is ready. Well, oftentimes, they do not hand us that package of material because most of that material is relevant to them. It's for demographic information, insurance information, et cetera. So we need to affirmatively ask them to give us that rating scale and look at it. That means you quickly score it to help inform how you proceed with the patient. And the same is true, for example, now, based on standards for Medicare, MEAC is now going to be once a year doing a rating scale for depression for all patients. And again, I had the occasion to have one of my patients be up for, per the computer, a depression rating scale. And it was fascinating to me because I had to go down and run. Now, this patient had no depression, so I wasn't worried about the results at that moment. But after I was done with seeing her, I went downstairs and I said, and there was no rating scale in my box, and I said, did her rating scale get done? And, or did she forget? They said, no, she got it done. We put it in the box to scan it. So they were going to scan it and put it in the medical record, which is what they're supposed to do. However, there's a good chance that the clinician, myself, might never have looked at that scanned material because it goes in as a miscellaneous report. I might have assumed that that miscellaneous report had already been looked at. So everyone, all this is, and this is not at all criticizing the folks in our clinic. Instead, it's all of us need to be system savvy, system savvy. And we need to know the system we're in, and we need to know the vicissitudes of the system we're in. So if there's little glitches in how things go, we need to try to figure out where the glitches are and come up with a plan of how to address them. Now, we can do that individually, which oftentimes we do, but even better as a system, as part of measurement-based care, we need to be able to have a standard structure to how those evidence-based rating scales are collected and given to the clinician so that we can use them during the session. So that's just an aside. It's just a funky little thing that's happened with our system as this evolves, and I think everyone's systems will have things like this, so figuring out what the process is going to be to make sure clinicians have access to the rating scales and also can utilize them during the session to inform care is how we make this measurement-based care actually more effective than treatment as usual. And if you don't do that, it's just a waste of time or a checking off of the box that we did check a measure, but it doesn't inform care or help you improve patient outcomes. Does that make sense to people? Okay, great. Any questions about that? All right. Oh, the other nice thing about measurement-based care is it can be utilized to demonstrate effectiveness of treatment to your patients and also to third-party payers. So I have seen this really be useful when I've worked with folks with obsessive-compulsive disorder. For folks that work with patients with obsessive-compulsive disorder, there's a sort of gold standard rating scale that's in the public domain called the Yale-Brown Obsessive-Compulsive Symptom Checklist. And then there's also a follow-up called the Yale-Brown Obsessive-Compulsive Severity Rating Scale, based on how patients fill out the symptom checklist. So one side of the symptom checklist are obsessions, the other side are compulsions. Patients rate whether they've had them in the past, present, or not at all. And then they bring that form in on the obsessive side, compulsive side, and the clinician, so the patient does their part, the clinician sits down with the patient, and you do a severity rating scale based on how compelling the obsessions or compulsions are and how much time they take from the patient being able to complete other activities in the day. So it sort of looks at impact of the symptoms. For folks with obsessive compulsive disorder, it can be so rewarding for the patient to see that they started out with a very severe case of obsessive compulsive disorder and now they're down to a mild case of obsessive compulsive disorder. And they can look at their symptom checklists over time and look at their severity rating scales. So that can be such a good feeling for patients to realize that they had such a difficult mental health problem and were able to work hard on it and conquer it in some ways. So that is sort of a really nice piece to measurement-based care that can both help patients feel like the hard work they've done is really paying off, and also can be a real boost to their sense of self. Since, as we all know, when people have serious mental health conditions, there is a sense of shame that goes along with that, and there's a tendency to view it as a character defect or as a weakness. So when we have things like measurement-based rating scales, which show that you do an intervention for an illness and the illness gets better, that can help patients really feel like, okay, this isn't me. I'm not a defective person. I have an illness that just needs work, and if I work on it and do treatment for it, things get better. And that can be another really, I think, cool part of measurement-based care. And I have a couple cartoons about how we feel about change. Why is change so hard? I just mean from the systems perspective. And sometimes we're trying to figure out a rationale for that. And in fact, it's especially discouraging when the change seems to impede doing your work effectively. So a lot of people have had enough experience with that they have a sense of learned helplessness, and that any interventions for change are going to be negative. The other issue, and this might be more applicable to someone like me who gets a little driven, someone's offering a wheel and the other two guys carrying the box of rocks are saying, no thanks, we're too busy. So that can also happen where you get so busy doing things the same way you've always done them that any change, even if it could be positive, feels like, oh no, I have to learn another new thing. I certainly have that with learning new computer programs, or we go as course directors, and once a month they tell us about all these new software applications we can use for our students. And I'm like, they're teaching me, I feel like they're teaching me calculus and I'm still on plus and minus. So I think that sometimes new innovations, you can just feel really stupid, and then that leads to some demoralization and some resistance. So, spoiler alert, who sets the standards? The Joint Commission sets the standards. It was formerly called the Joint Commission on Healthcare Organizations, also called JCAHO. All of us who've been around a long time slip into calling it JCAHO, but I actually looked this up for my own information because I was one of those people that called it JCAHO. The name was actually changed January 1st, 2007. So I don't think it's a new innovation with this name. It has been around a while. I just have to get used to the new name. But for people that don't know the name, you can learn it correctly the first time till they change it on you. To earn and maintain the gold seal of approval, you need to undergo an on-site survey every 3 years. Has anyone here ever been through a Joint Commission survey, participated in one? A number of people. How was it? Was it fun? You're saying no. No, it's usually not fun. There's this sort of sense of pressure from the people that are helping head up from your organization. The visit with Joint Commission, a lot of times they're going around talking to the different units of an organization, telling you what you must do, what you must not do. For God's sake, don't say this. I mean, you will hear things like that. So, or they will come and quiz you and say, what if they ask you about this or this? They're going to ask you, so you better be ready. So there is a bit of a sense that if you think about the Jaws music, dun and dun and dun and dun, it's kind of like that. It gets louder and louder, and all of a sudden there's a huge bite out of your boat, and you're barely hanging on. So Joint Commission visits are kind of a big deal, and that is because they are pretty scrupulous, and they have a lot of things that they expect organizations to do in order to be and stay accredited. Joint Commission is the oldest and largest standard-setting accrediting body in healthcare in the United States, and accreditation and certification is seen as evidence of quality and dedication to meeting performance standards. The standards focus on safety, effectiveness, quality, and value. And I wanted to just show you what the gold seal looks like. There it is in the right-hand corner. And when agencies earn that gold seal, they're very proud of it, and they use it as part of marketing efforts with both healthcare payers as well as patients. And just so people know, what are the kinds of organizations that are accredited by Joint Commission? Because some of the students here may not know that. So the kinds of organizations that get Joint Commission accreditation include general hospitals, psychiatric hospitals, children's hospitals and rehabilitation hospitals, critical access hospitals, medical equipment services, and other long-term care facilities like nursing homes, behavioral health care organizations, addiction services, rehabilitation centers, group practices, office-based surgeries and ambulatory care providers, and independent or freestanding laboratories. People may wonder, does ETSU, MEAC clinics, are we accredited by the Joint Commission? And we are not currently accredited, nor are we required to be certified because we are not considered a behavioral health care organization or an ambulatory facility. We don't meet the definition of that, but we are considered a multi-specialty physician's practice with physicians that have privileges in facilities that are Joint Commission accredited. So that's a slight difference. And I put that the determination was made to change the standards effective 1/1/18. Yikes. We have a little guy, that's us, on the surfboard. He's getting really concerned because he sees a little tiny shark fin pointing up. And then one of the sharks says to the other, should I stick my whole fin out now? Sometimes what we thought was an anticipated change ends up sort of like, coming up fast. So that is one of the reasons that Dr. Goodkin wanted our group to become more aware of this anticipated change so that we could get mentally prepared as soon as possible for some of the changes. The change in standards, as I said, is effective January 1st. And I have here the current standards, all in black, and you see the new standards as of January 1st also in black, but the red additions are the specific changes that Joint Commission has asked for. They made it evidence-based rating scales during encounters, like I've already talked about, and to assess frequency and severity of symptoms, which meant they needed to be used at intervals, not just at the time of initial eval, and to support standardized assessment and clinical decision-making. Let's see if there's anything. Okay, and again, these need to be used with frequency and during the clinical encounter in order to improve care over usual care. So those, if you take home nothing today but that, you need to have frequency of use and look at it during the encounter. So evidence-based rating scales are also known as patient-reported outcome measures. Those are probably the two most common terms. They are pillars of measurement-based care. They are quantifiable, standardized measurements of changes in symptoms, both frequency and severity of symptoms, and they also look at functional impairment or substance use over time. They are, at their best, easy to administer, interpretable, reliable, and sensitive to change. That's why the measures that were recommended were in part chosen based on those things. They allow quicker change and fine-tuning of treatment plans when used with frequency and looked at during the encounter. And they also have a nice side effect benefit of helping patients become more disease and symptom knowledgeable, because simply by asking people with frequency over time to monitor, about these symptoms, you're telling them these symptoms are part of what can happen when people have the illness that you have. And you're also saying, these are the things that I'm watching for to see if our treatment is working. So that is really important, because helping patients learn more about their illness is critical. And certainly in my time working with patients, when I've had patients who have something like bipolar disorder and they keep on top of that literature and they come in and tell me, have you seen this study that came out? Have you seen this new thing? That is so helpful to me because they watch their illness in a way that probably no physician will watch it, because it's their number one, it's the thing that most impacts their life. It's a high priority for them, and they really want to do their best. And so I have had patients that do that, and that can be super helpful. It's kind of like what I tell patients who are working with an attorney. I say, don't count on the attorney to watch for all the details. You keep on top of your case yourself. You may need to remind your attorney of certain issues pertinent to your case, because the attorney can't keep every detail in their mind, and you know your case the best. So I think get expert help. Use that expert help to help guide what you do, but also be on top of your illness yourself. And measurement-based care, when used with frequency, can really help patients learn to do that, even if they didn't have an inclination towards it. Measurement-based care, again, it sort of makes sense that it aids in effective and timely clinical decision-making. And what measurement-based care is not, it's not a replacement for perceptive clinical symptom assessment, not a replacement for clinical judgment, but also vice versa. Doing measurement-based care and doing those rating scales also complements astute and perceptive clinical judgment and assessment. The data suggests that properly used measurement-based care augments and improves outcomes over care as usual. So I thought it would be helpful to look at some of the types of psychometrically validated tools. And if only we could do that. That's kind of the Dr. Hendricks approach to psychiatry. Look at the brain pathology up close. All right, there are diagnostic specific instruments, and they are tools that are used both as screeners and to assess severity. So you can use them to monitor over time effects of treatment. And we have them for depression, for bipolar disorder, anxiety disorders, post-traumatic stress disorders, schizophrenia, substance use disorders, obsessive compulsive disorder, as I mentioned. These are just some of the categories. So the focus of the tools is to screen and to determine symptom severity. So again, I feel like I'm doing the Ronald Reagan approach to a talk. It's not just to screen. Remember, the Gipper was famous for saying the same thing 6 different ways so that people got it, because they heard it enough different ways. And I think that's really important. So ongoing use, not just screen, used during the meetings. They are mostly the ones that are currently being recommended patient report based, but some are clinician based or clinician based on interview of the patient. And then they can be used to assess both symptoms and level of functioning. And just to say the same thing a different way, the research shows that screening and diagnosis alone does not improve clinical outcomes. So you see how it's the same thing in a different way. Sorry to do that so much, but again, that's a really important point. There are a number of different tool types, and there are types that are for screening, for outcome monitoring, for functional status assessment, and there are sort of multi-diagnostic support instruments. So just to give you some examples of the kinds of screening tools that can be used, because some people here may know a lot about that and some may not know very much about it. So these are some adult symptom rating scales for core outcome measures. So the PHQ-9, probably everyone that's familiar with MEAC clinics knows about this instrument. It is our go-to. It's the patient health questionnaire 9 is for 9 items. It's a depression screener, but can also be used to monitor severity and progress over time. There's also a thing called the Altman scale, which is used to look for mania, and it is a 5-item scale. There's the GAD-7, which stands for Generalized Anxiety Disorder 7. Looks for generalized anxiety disorder, and it's a 7-item scale. The PCL is for PTSD. Again, it's got 20 items. Some of them are a little more complex. Some of them are less. PDSSSR for panic attacks. A lot of people know about the Audit C. It is used for an alcohol screener. The DAST-10 for drug abuse, and the PHQ-15 for somatization problems. And I thought it would help to look at some, and don't panic. You may have to do the panic inventory. These are really, this one's hard to read. of adult multi-diagnostic substance abuse outcome measures. For example, the SAOM, which is the Substance Abuse Outcome Modules, and the Brief Addiction Monitor, or the BAM, are both given as examples on the Kennedy Center brief. But I did not give you an example of what the SAOM is used. It's been used by a lot of facilities. It's used to monitor adults who are in an actual treatment facility, a substance abuse treatment setting. There are 4 components to that one. There's a patient baseline assessment. There's a clinician baseline assessment of the patient. There's a patient follow-up assessment and a medical record review. There's different components that are fairly extensive. So the measures do assess sort of change in substance consumption over time, symptoms of dependence, and also general functioning. So it's called a module. It is a module, and that is one that would be a sort of specialty use depending on where you were housed with your practice. There are additional adult functional status rating scales for core outcome measures, and those include the Functional Outcome Survey. It's used for general medical and mental function status, and it has fairly complex scoring, and it's similar to 2 assessments, the SF-36 and SF-12, that may not be public domain. There's also the Daily Living Activities, which looks at functional outcomes, and the World Health Organization Disability Assessment Scale. I tried looking for a couple of these, and I could not find them online easily, so unfortunately I don't have a copy of that. Something that people did not get to see at the Psychiatry in the Mountains presentation that we recently had, looking more in depth at measurement-based care, were child and adolescent rating scales. And since there's a number of people here who are interested in child and adolescents, I thought it would be helpful to show some, and also to maybe give some examples so people in the audience know the kinds of things we use with kids. So there's the pediatric symptom checklist. It's a psychosocial dysfunction scale, and it's clinician completed. The modified checklist for autism in toddlers, also called the MSHAT, and it looks for autism spectrum disorders, clinician completed. The CRAFT, probably a number of people may have heard of that one. It's a substance abuse rating scale. And then the mood and feelings questionnaire that is filled out by the parent and youth. And you have to really look at the ages that these rating scales are validated for in kids. Because for some of them, if you get outside the ages they're validated for, they are no longer valid. And some of them, they will say, if you look on this site, well, it is rated for these ages, but we have found thus far that you can also use it in younger kids. So it really depends on the rating scale you're using. You'd need to look into that if you tried to use it with a younger kid. If it didn't have validation, there's no use doing it. So this is a bad one. The MSHAT-R is rating scales. The patient questionnaire adolescent version, it screens for depression and dysthymia for 12 to 19-year-olds, 9 items done by the youth. There are 2 Vanderbilt ADHD rating scales, one for parents and one for teachers, and they have slight changes in them because obviously there's different questions and different settings that are relevant to each role. They are, the parent one's completed by the parent, the teacher one's completed by the teacher. The nice thing that Vanderbilt did, the really smart thing, was they made this public domain. Initially, you had to go through Vanderbilt to get it so that they could keep track of who was using their inventory, so they could collect data, go back. Now it is on the American Academy of Pediatrics site. You can download it. There is one other public domain, really nice ADHD rating scale called the SNAP, S-N-A-P. However, what Vanderbilt offers for people in East Tennessee is most of the teachers are Vanderbilt familiar. And probably in the state of Tennessee, a lot of teachers are used to doing it. So they're like, oh yeah, I know this. They can complete it fairly comfortably. The other nice thing about the Vanderbilt is they have some screening questions that look for oppositional defiant disorder and conduct disorder, and also for some performance questions that look for things like potentially learning disabilities in kids. So those additional questions, in my mind, make it superior to the SNAP. Again, this is just more the Vanderbilt ADHD rating scale, the teacher form. And then I love this one. It's called the Scale Child Assessment of Anxiety and Related Emotional Disorders, the SCARED questionnaire. It's great because it assesses for anxiety disorders in children. And I love that acronym because it fits perfectly. It looks for generalized anxiety disorder screens, separation anxiety disorder, panic disorder, and social phobia. So really nice instrument. It is for 7 to 17-year-olds. There are parent form and youth form, and kids do this really nicely. And it is not uncommon. I use SCARED a lot with the kids I see, and it is really common for children to endorse a lot of anxiety that parents didn't know was happening. So I think that it's really nice when both the children and the parents fill it out, because it helps you, because sometimes parents just see this angry, irritable kid and they think they're just a little, hellraiser, hoodlum, and actually, you've got an anxious, fearful kid underneath a kind of, growly exterior. So it can be really important to use this screen. It's another bad screen with a lot of Went to a physician and got a rating scale and then said, oh, you have ADHD. There was no clinical interview. Stories about college students or high school students who read a blurb on ADHD, went into their doctor, spent 5 minutes, said, I've got these symptoms, and in order to score an amphetamine class medication, resultant significant drug problems in some young people. So I think being really careful, again, using rating scales to inform clinical decision making, but not to make a diagnosis. And this is just another page of it, just to give you an idea of, so and there's also a classroom behavioral performance part that looks at behavior issues like disrupting class, et cetera. This is the scared, and I don't know if people can see that. I think I went up there and people couldn't see it. Can you all read those questions? Or let me give you some examples. And sorry about this. So I have to confess, I have Dr. Lywell in the audience, and he just really abhors the use of screen capture. But I did not know another way to do this short of writing this down. So I will apologize in advance because I feel like I have someone there who really wants this done right. So Dr. Lywell will probably forgive me for this. So this is a long questionnaire. There are 2 pages. Here's examples. When I feel it's hard to breathe. I am anxious. I worry about being alone, so et cetera, et cetera. They're all different questions. They're categorized into different diagnostic categories for the anxiety disorders. And here's page 2. And basically, children go through it pretty quickly. A total score of 25 or more may indicate an anxiety disorder. Higher than 30 are pretty specific, and that means you need to do more investigation, but it looks likely. So what are the benefits of measurement-based care? Again, when properly applied, the data says there are better outcomes for patients, that you can enhance professional development via the use of aggregated symptom rating scale data to inform your practice groups. You can improve quality of care as a practice group and as an org. You can demonstrate the value of mental health services to payers, third-party payers, which is always an issue. And you can, this is dreaming, but positively influence reimbursement of policies. I'm sure people saw the big study that came out yesterday, endorsing what I already knew here from our MEAC practice, which is primary care providers are paid on average 20% more for the same the same billing code for, say, major depression. So a pediatrician would be paid more than me as a board-certified child psychiatrist to evaluate a child with autism spectrum or a child with post-traumatic stress disorder. Insurance companies are doing that across the country. All the way up to a 69% difference in pay. So as we look at what is happening to dwindling mental health providers, looking at how mental health providers are being reimbursed is a big concern. And if you talk with any pediatrician, or it's been my experience, they all are like, there's not enough of you all to see all the patients that I'd like you to see. So reimbursement is a huge part of that, and certainly the big study that came out yesterday and was featured in APA Times is further endorsement of that issue. So in summary, the organizations for which Joint Commission has oversight will need to be implementing the new standards as of January 1st. The new standards require organizations to implement the use of standardized instruments to monitor patient progress in care, to use the data generated to inform the plan of care, and to evaluate treatment outcomes for the population served based on aggregating and analyzing the data gathered. This is a close-to-home cartoon and you have the boy saying, okay, let's see, Will is on a train traveling north at 50 miles per hour, Peter's on a train traveling west at, and he has his train set in his tracks, suspecting that just such a word problem might be on the algebra midterm, Gary came prepared. So this is your way to become better prepared. That may give a trauma flashback to all of you pre-meds who had to take physics and go to sleep with that physics book every night. And this is just a bibliography. And so you're telling me data can drive logical and transparent decisions. Any questions?
Yeah, Dr. Bird, I do have one. First of all, we try not to open the head when we're actually working on the brain. But give us time. Anyway, the question I have, are you implying that each time an encounter is entered in the computer, we're going to need to have some kind of a measurement-based care? Because in particular,
No.
with ECT, I get concerned about it because they've got post-anesthesia delirium. Not a good time to assess.
No. So right now, thank goodness, that is being left to clinical judgment. So, for example, if you instituted an antidepressant, it would not be reasonable. You would not even expect to see a primary effect till about 2.5 weeks. So there would be no use in assessing at the 1 week mark, for instance. But certainly, you would look at proper intervals over time depending on the condition. So, and depending on the interventions done, and depending on if the patient adhered to the treatment. You know, there's a number of factors that could make it complicated, but certainly someone that's delirious or has post-ECT confusion, that would probably be a worthless assessment. So no one's expecting, and I'm glad you asked that. No, it's not that you have to do this every single encounter with every single time you see the patient. You do it at intervals that you think are reasonable based on the kind of treatment that, you know, the intervention of treatment you're doing.
Yeah, I am thinking about doing memory review prior to anesthesia. And then the other thing that we see with the ECT cases in particular, sometimes if they go 2 weeks in maintenance, they're really in rough shape when they come in.
Yeah.
So memory assessments are one thing, probably not affective assessments, though. Those at different intervals.
I think that I'm really glad you asked that question because it's important. Okay.
Dr. Bird, I have an issue with equating evidence-based rating scales with patient-reported outcome measures across a number of disorders. So I wondered if first you would comment on that, and also specifically, what would you say in terms of measurement-based care options for neurocognitive disorders?
The first question was, you have trouble with equating measurement-based care.
Evidence-based rating scales with patient-reported outcome.
Right, with patient-reported outcomes. So do you mean patient-reported outcomes like on interview?
So, right, if you're analyzing a patient's behavior, if you will, on a clinical rating scale, that's not a patient-reported outcome measure.
No.
But it is an evidence-based rating scale.
Right, it is. It is. So you're trying to make sure people understand the difference. Okay. Yeah, thank you for doing that.
Right, because I wouldn't, I hesitate to say, you know, they're exchangeable terms.
Yes, okay.
Though they are sometimes referred to that way.
Okay, very good. I appreciate that. And the other question was?
Was about measurement-based care options for neurocognitive disorders.
Well, I did not see anything in my review for just looking at Joint Commission standard change, but you may be the best person to comment on that, or Dr. Lightwalla. We have a couple of experts here, and maybe others that I don't know that are in the room, for what you would recommend. I can think of the usual things we use, and I can think of things like the Lurie in Nebraska and the Halstead-Raitan, which are big deal tests and quite expensive, so, cost versus benefit, but certainly things like the MoCA, any mental status, is that the kinds of things you were thinking about?
Right.
Okay, all right. Anything else that you all think? No? Okay, so how often do you all think that should be monitored for people with dementia? What is there any kind of consensus on that? I do not know the answer to that question.
Yeah, I don't think there's a consensus on it. I generally monitor at every visit, and it's monthly. typically. So I'm looking at that very closely in response to intervention and
Okay.
trying to tailor my treatment accordingly.
So, okay, all right. So just for students here, the Lurie, Nebraska, the Halstead, Raitan are big, very comprehensive neuropsychological testing batteries that can be used to help ascertain level of functioning and also presence of things like dementia or possible presence, as well as things that can look at executive processing, things like that. So they're used for a bunch of things, but they take a lot of time. For seniors, they can get tired doing them. You often need to break it up into a couple sessions or 3, and they're quite pricey. So things like the MOCA that students are familiar with, the many-mental status, those kinds of things are a lot easier and, cheap, not a cost to the patient. Did you have a question?
I think I do. So let me kind of go with that, and then maybe we can go the other direction. Thank you so much for bringing this issue very much to the forefront. I think it's very important that we all need to know it. And I think, particularly from the trainee standpoint, I think it's important that they realize how critical this is. And to address what Dr. Goodkin has asked, the scales will inform patient outcome if you use it correctly. So I think that's kind of what you were trying to say. It's not the same thing, but that's what you want to use it for, is to inform outcome. And one of the things I've, for a long time, used is just actually something like a 0 to 10 or a percentage change. We talk about how, if there's a certain amount of percentage improvement with an antidepressant, then you proceed in one direction versus you augment versus you increase dose, et cetera. So I think even something as quick as that can be helpful and can show the reimbursement people that we are monitoring, and that can be done at every visit, and can also inform the patient because, they may have a number that isn't seem consistent with their clinical presentation. So I think that's very important. The other thing that I thought was a very easy one from a disability standpoint is the Sheehan Disability Scale. It very much, very globally, at like a visual analog scale kind of scenario, or 0 to 100 kind of thing. They look at the work, the social, and the family commitments, and the number of days you missed, and the effort that you had. So you can be there, but be unproductive. So that's something that's really useful. The question I had with the Kennedy Forum, that you talked about is, why only primary care and behavioral health? Why not other subspecialties?
I do not know the answer to that question.
Okay.
It's a good question, but I think the thinking was that those are the 2 subspecialties, or the 2 specialties most likely to evaluate and treat people with mental health conditions. OBGYN usually falls under
Right.
primary care in a lot of categories, not always, but a lot of women go to their GYNs for their primary care. So they end up, but it would be family medicine, internal, OB, and psychiatry, as well as, other mental health professionals.
And just to support the issue of that, psychiatry is not getting reimbursed enough, is now that we've got our expectation of the physical exam referrals and things, it takes away even more of our time. So.
Any other questions or comments? Well, thank you all for being such a kind, receptive audience. Appreciate it.